Hey, guess what time it is? It is 4 o'clock in the mountain time, which means 6 o'clock on the East Coast, and that is one time only. It is time for Fertility with Fink and Friends. I am Fink, you are Friends, and I am sure happy to see everybody. Looks like Laura Marie was the first one to join over here on this side, and I see Megan Michelle. Thank you for being number one. So we've got a couple of different Instagram feeds here. We've got Facebook and YouTube and LinkedIn right here in the middle. So live from Colorado Springs, where it's a lovely 85 degrees outside today, 85 degrees. And I'm Dr. Randy Fink, the clinical director of IVF services here at CNY Fertility, Colorado. And I am also the medical director at CNY Fertility at the Miami Center of Excellence in beautiful South Florida. And again, sure is great to see everybody here. I see Kelsey and Grace Hannah, and I see Staley. Hi, Staley, my friend Staley from Miami. Our beautiful PCOS therapist tells me 26 weeks this Friday. God bless you. What a wonderful, wonderful gift you have there and sharing it with us. I missed in Miami. Thank you very much. And over here we've got the Florida girl, Cass Newer, Aaron, Eliza. Oh gosh, the list goes on. Thank you so much for being here, and hi to Lisa over there on the Facebook side. So I hope you've had a very good week. It is, as always, very interesting over here in the work that we do in helping folks expand their families. I want to send oh gosh, and look what just happened there. So I'm not sure if you guys can see, but once again, my lovely mother has just joined on the Instagram side from a beautiful southern Alabama. We call that LA, Lower Alabama, Mobile, Alabama. Thanks to mom and dad for watching and seeing what I do for a living. So I was going to send a special shout out to my friend Lyric. Lyric Aikman is one of our global team nurses here at CNY Fertility, who has the great responsibility of caring for all of you who come from afar to be treated by us in one of our locations at CNY. And Lyric, thanks for all that you do. And Lyric used to be a nurse here in our office, and now she works from home. She has I guess probably not a new baby anymore, but she had a baby a little while ago. I guess, that may have even been over a year ago at this point. Boy, time really, really flies. I wanted to also send some special thoughts out to some friends of mine who are kind of dealing with a tough time right now, and I'm sure it's something that everybody who's watching here can relate to. And that is they have undergone the IVF process, and they made some embryos, and they did an embryo transfer. In fact, I think they've done more than one embryo transfer. The embryo went back in, and for celebrate, jump for joy, had a positive pregnancy test. And gosh, that is the greatest thing. What a great feeling. All the hopes and dreams and possibilities for the future that go into having that positive pregnancy test. But then as we followed her blood tests, we found that the hormone level was not rising appropriately. Typically what we expect with that beta HCG, and that's the pregnancy hormone that we check in the blood, we expect in most people and in most normal pregnancies that hormone level will double every 48 hours. And so usually what we do is every 2 days we'll check a hormone level and see that the number is in fact going up and doubling. When it doesn't, it means one of two different things. That's sometimes the indicator that we have to be on the lookout for an ectopic pregnancy or a tubal pregnancy, a pregnancy that is not inside the uterus. And that's a potentially life-threatening thing. So we really pay very close attention to that. But fortunately, rather than being a life-threatening issue, more often than not, what ends up happening is that it is simply a pregnancy that is not going to continue, or what we'll call a non-viable pregnancy, a pregnancy that's not growing appropriately. And the heartbreak that goes in with that is something that I think that we can all feel together. So for everyone who is dealing with that possibility of a pregnancy test, a hormone level that's not rising appropriately, um, and what that means to us. I just want to take a moment to say, I think everybody in this community can feel for you and what you're going through there, because when all those hopes and dreams are suddenly dashed and you're told that things aren't normal, the ache that causes, the feeling that you get in your chest, I certainly feel it with you there. Usually, what happens in that situation is that we'll get an ultrasound, and we'll see what the ultrasound shows. And fortunately, in her case, we are seeing that that pregnancy is inside the uterus, that it is not, or does not appear to be, an ectopic pregnancy. But nevertheless, thus far, it doesn't look optimistic about continuing. So for all those people who are losing that optimism, I just want to throw out my own thoughts and prayers and feelings, and I can assure you that this entire community is here with you, supporting you. And speaking of optimism, today's little story I want to share. And once we do this, we'll get to questions. And gosh, I see a bunch of questions already coming in there, and I really appreciate that and everybody being here with me. I would like to just share a little story about a woman named Wilma Rudolph. Maybe you have heard the name, and maybe you haven't. That's okay, because she was born June 23rd, 1940. 1940. She was born prematurely, and in those days, a premature birth was not likely one that would result in a child going home from the hospital. But in her case, it did. She was born prematurely. She was able to overcome that obstacle, but she contracted polio as a child and ended up with a twisted leg and a twisted foot. And in those days, polio, now we're all vaccinated for polio, and it's fortunately something that we in our lifetimes will likely never really have to deal with. But she was told that she would never walk again. And that just wasn't an okay answer for her. So she got involved and actually even developed, even as a youngster, many of the paradigms in physical therapy that we know now. So that she could relearn how to walk. And then eventually, as she grew on into high school, she became very interested in running and in track. And as it turns out, Wilma Rudolph was a three-time Olympic gold medalist. And was a woman who was told that she would never be able to walk again. And I think that, and in addition to that, Wilma was also a woman of color. And so, in the 1950s, there was so much adversity that she faced trying to be a professional, become a professional athlete, and even just to overcome the obstacles that were presented to her from being able to walk, just to walk. She went on to do pretty doggone well for herself, I would say, and is really an inspiration to show us that, even in the face of that kind of adversity, we can choose to remain optimistic, and in so doing, really face our fears, to look adversity in the face. And again, that's like we've said in previous weeks, courage is not the absence of fear. It is the willingness to look fear in the face and to overcome it. And I think Wilma's story is something that hopefully will provide us all with a little bit more inspiration this week as we face our own adversities, as we climb our own obstacles, and as we do what we have to do to try to remain optimistic about our futures. And as far as that future goes, that's something that we really want to help you with. And so that said, let's start turning to some questions here. Looks like Katie Johnson over on the Facebook side. Hi, Katie. Does myoinositol or D-chiromyoinositol help with ovulation? Yes, it does. So inositol is a supplement that you can take that really is the same, it serves the same function as a medication that we often use in fertility treatment known as metformin. Now, metformin is a medication that is intended for folks with diabetes. What does it do? It treats blood sugar. We know it in the fertility world is also something that we give to women with polycystic ovarian syndrome. And through its various mechanisms dealing with insulin resistance and some other things as it pertains to the ovary, metformin can help to restore normal ovulation. Inositol or D-chiromyoinositol or myoinositol, they're kind of called by different things there, but they're really the same thing, functions in the same way. It has an effect on dealing with insulin resistance and can help to restore normal ovulation. But what else does it do? Because it has another really important function. We often use metformin in the IVF world for women in whom we are trying to improve egg quality. And it's all about the egg, right? And that's what we've talked about before. It starts with the egg. The egg is the most important kind of feature in the IVF world, and metformin or inositol can also help with egg quality. So we will all very commonly put women on either inositol or the prescription metformin to help them with their egg quality as they proceed with IVF. Now, which one's better? And do some people ask, do I need to be on both? I'll tell you, when we prescribe for you metformin is probably about $10 or so for a bottle for a month's supply, whereas a good bottle of inositol is probably about $25. And even though I do have my list of supplements that I feel incredibly strongly about that people should be on when they're undergoing the fertility process, and I'm happy to send you that list. If you don't have it, just Instagram message me, and I'm happy to send it to you. Or if you don't have mine, well, it should be on your screen. Maybe it's on your screen there. But Brandis Courtney, her Instagram, our nurse practitioner here in Colorado, we're happy to send you that list, which comes directly actually from this book. It starts with the egg. That may be backwards, I think, here on the Instagram side, but you get the picture. You know what I'm talking about. These things can make a huge difference. Metformin is cheaper and it's pharmaceutically manufactured. So like I started to say, even though I feel very strongly about these supplements, one of the problems with supplements is that because they are not regulated by the FDA, the manufacturing process may not be consistent. And so there have been studies that show that when you go into someplace like the vitamin shop and you pick something, a bottle of something off the shelf, that it may not contain what the label says it contains. No two pills may have the same amount, that the quality control in the nutraceutical manufacturing process is not the same as it is in the pharmaceutical manufacturing process. And so for that reason, and just simply on a cost basis, I'll usually say, if I'm having a consult with someone, let's start you on metformin. If you would rather take the supplement, you can. Katie, there's not a particular brand. I have one that I recommend that's on my supplement list, and I'm happy to send it to you. But really, the most important thing is the amount, not so much the brand that it's in. Okay, so let's see what else we have here. Here's one from it looks like Jasmine Leah. if I'm saying it right, Jasmine, lay a W. I hope so. Forgive me if I mispronounced it. Going into my fourth transfer with two miscarriages behind me, with euploid embryos. And oh gosh, I'm so scared to lose another embryo, and I know that you are. But you say here you won't give up, and that's the kind of spirit that will get you a family. So when we have a euploid embryo, we expect about a 60% probability that you will be able to get pregnant with that embryo. Now, that still only means about a 50% probability of an ongoing pregnancy. So, given that miscarriages, the most common reason that happens is due to a chromosomal issue or a genetic problem in the embryo itself. How does that even work if you're dealing with a PGT tested or a euploid embryo? It's been tested, right? So they know that the chromosomes are normal. How can you still have abnormal chromosomes that's going to result in a miscarriage? Well, it's a good question, and I think it's one that bears talking about, and I think everybody should know it because a lot of people feel like they should be doing PGT testing because they want to have a normal baby. I'm going to do that testing because, I just want to make sure that my baby's normal. Well, PGT testing doesn't have anything to do with whether you will have a normal baby or not. What it's really designed to do is to take a group of embryos, hopefully a larger group of embryos, and help to sort out which are the embryos that have the greatest probability of being able to get you pregnant. Because if we can test them and we can see that we believe that they are normal, that embryo has a 60% probability of getting you pregnant. But what are they doing? They are biopsying the portion of the embryo that becomes the placenta. So they're not biopsying the baby. When we look at an embryo, there's something that's called a trophectoderm, which is the outside part, and then there's the inner part, which is called the inner cell mass. It's the inner cell mass that becomes the baby. The trophectoderm becomes the placenta. And so there can be some what we'll call discordance with this, that you can have a normal placenta and an abnormal baby. Or conversely, you can have a normal baby with an abnormal placenta. So even if the PGT testing says that your embryo is chromosomally abnormal, there is still a possibility, and it's anywhere from a 5 to about a 15% chance that that embryo will still result in a normal baby. So it's not a perfect system. But if we do testing and we say, hey, we've got a euploid or chromosomally normal embryo here, why is that still going to result in a miscarriage? Well, maybe one of two reasons. One, either the biopsy wasn't correct, that it was a normal placenta, but without a normal embryo. The baby itself was not normal. Or, the other thing, it tells us that it believes that the chromosome part or the genetic part is normal, but it doesn't say anything about that, those hundreds of millions of little chemical processes that are all happening within that embryo, all of which have to be normal in order for that embryo to continue to grow. So even one little thing that's gone astray there can result in an embryo that doesn't grow, and sadly, in a miscarriage, which, as I have said before in this forum, is insult to injury, because having gone through the process of IVF and having a retrieval and having a transfer and doing everything right and getting pregnant, only to have that pregnancy end in a loss is really a very hard thing for all of us to stomach. So hopefully that answers that question there. Hi, Ruzik Blue from Las Vegas. Nice to see you. Does a day 3, this comes from Kelsey Lindsay 1, does a day 3 basically fair quality 9-cell embryo have a decent chance of being a viable pregnancy? The answer is yes. Yes, it does. What does that grading business even mean? This is something that we've talked about before here, and I will tell you that it's a constant uphill battle for us as providers to share this information with you, which I know that you hear, but then you look at social media and everything else, and it becomes a very hard to understand because we are all so conditioned to know that we are graded on everything. I'm graded every day here. If somebody doesn't like what we do, they're going to write about it on social media. Somebody's going to say something to friends. They won't want to send a friend. I'll take that very, very personally. And when I see someone who isn't happy, it really personally affects me. Well, that's how I'm graded now. But we've all gone through high school, right? And we know that you get a grade associated with your performance in a given class, and that grade tells you where you fall relative to everybody else in the class, right? So if you got an A in English, it means that wow, you kind of did all your homework and you were probably better than average, depending on how the teacher grades things. That you're ahead of the curve. It's an excellent grade. It means to say you're probably better than most people, at least in terms of your performance in that class. Whereas you got a C in physical education in your PE class, which means, well, you weren't probably as much of a jock as you thought you were. That puts you kind of in the middle of the road, but your parents always gave you a bunch of crap because you got C's instead of B's and A's. And, everybody wants to judge you. Everybody wants to grade you, and everywhere you turn. Well, unfortunately, on some level, that's life, that people are kind of always grading us and always trying to judge us one way or the other. But in terms of embryos, embryo grading, is not to see who's at the head of the class. We always say it's a beauty pageant. It's kind of designed to be a scale by which embryologists can look under the microscope and classify things that they see, and score things based upon the number of structures or what these structures look like under the microscope. Well, the original point of that grading was to try to see if there was some way to be able to look at an embryo and tell whether it was chromosomally normal. Because remember, again, that chromosomally normal embryo has the highest probability of being able to get us a pregnancy. Well, as it turns out, the answer is no. The embryo grading really doesn't so much correlate with outcomes. And anyone of you who has had PGTA testing, who knows, who has looked at that report, the grading may show you that the ugliest embryo in the batch, the one with the lowest possible grade, that we might have never otherwise chosen to transfer into you if we judged it based on grade, that embryo may be the only one that's chromosomally normal, whereas the beautiful, highly graded embryos may have some complex chromosomal abnormality that would be completely inconsistent with life. So I would like for you, if you can, to suspend your disbelief in the idea that where we are graded, at least in terms of IVF, has some realistic bearing on our outcome. So we will pick the prettiest embryo to transfer. Typically, what we do that. But if you have PGT tested embryos, the tested embryos, once it's tested, the grading really doesn't matter so much anymore. It looks like Toyin is asking about mosaic embryos. Are they transferable? And the answer to that is yes. So a mosaic is a type of embryo that is not, that from the testing shows that it's not completely normal, but it's not completely abnormal either. Well, there's a lot of data that's been looked at on these mosaic embryos, my friend. And let's talk about that, because any of you who end up doing PGT testing may have an embryo that says high-level mosaic or low-level mosaic. Okay, so one way to think about, well, what is a mosaic? It is a combination of both normal and abnormal cells, at least in the trophectoderm, or the portion of the embryo that becomes the placenta, a combination of normal and abnormal. Well, what does that mean? I don't want to have an abnormal baby, right? Well, none of us do. But what we've learned about this is, okay, so if you have an untested blastocyst, so let's call it a day 5 embryo that you did not do the PGT testing on, that embryo has about a 30% probability of being able to get you pregnant. If we've tested the embryo, we did PGT testing and it says that it is a euploid embryo, then that gives us about a 60% probability of getting pregnant. In most cases, the mosaic embryo gives us about a 40% probability of getting pregnant. So not quite as good as a euploid, but still better than an untested embryo. And the data shows us that nearly 100% of those euploid embryos, if they implant, of those mosaic embryos, nearly 100% of the mosaic embryos, if they implant, will result in a normal baby, just as normal as your euploid. So it hurts me when I hear that there are some practices that tell patients that they should destroy their mosaic embryos because there's at least a 40% probability, roughly, that that embryo will give you a baby and a normal baby at that. So yes, mosaic embryos are transferable. Lisa's asking, how accurate is PGT-M testing? So we talked about PGT-A. PGT-A is where we're biopsying the trophectoderm, or the portion that becomes the placenta, to see what is the chromosomal makeup of that embryo, and we can tell gender. So that's how we do gender selection. We tell if the embryo is a male or female. But PGT-M is another type. It's still the same biopsy, but it is looking for a specific mutation, a single gene mutation, particularly something like a disease state. So this is the reason that we recommend everyone does a genetic carrier screening test, which is now the standard of care. And what that carrier screening test does is that it tells us whether you are a carrier of any one of about 500 or so different genetic diseases. There's 500 of them, and I'll tell you, some of them are things that that I've heard of. There's cystic fibrosis, there's muscular dystrophy, there's sickle cell disease. There are things like that. I will tell you that most of these diseases are things that even I've never heard of, or certainly never seen in my medical career, because many of them are pretty rare. But if we have, if you, let's say you, female member, are a carrier of a disease, then we want to test your partner or the sperm donor. Because if the sperm donor or the partner carries the same disease, it gives you a 1 in 4 chance of having an affected baby. So obviously we want to find out about that before we get pregnant, especially if we're going to be doing the process of IVF, because we can prevent you from having an affected baby, which sounds like a great idea to me. Well, so when we find one of those diseases and we want to prevent it, that process is PGT-M. It's looking for that single gene mutation. And what they do typically is, if they don't have one, they will build a probe, a genetic probe that looks for that particular gene sequence, and they're able to identify it in the portions of cells that come from your embryos. And yes, it is very effective. Again, it's not there. Nothing in our world is perfect. It's not a perfect test, but it has come a long way and is very, very effective. Let's see what else we have here. I am supposed to start letrozole tonight for my modified natural cycle. I'm just curious to see my thoughts, or your thoughts, on letrozole. My issue is tubal ligation, very regular cycles, 9 follicles on each side. This comes from Delaney. Hi, Delaney. I'm a little confused about that. You're talking about, you're talking about doing an embryo transfer, and there's really three different ways we can do an embryo transfer. There's a medicated cycle. The medicated cycle has been around since IVF was invented. Probably 85% of the cycles in the United States are medicated, and that's where we give you 6 to 12 days of estrogen, followed by 6.5 days of progesterone injections, followed by an embryo transfer, followed by progesterone injections through about 10 weeks of pregnancy. There's your medicated cycle. The natural cycle is where we let your body's own hormones contribute. So we let you develop your own egg. We can trigger your body to release that egg, but making the egg or developing the follicle as it grows, that creates your estrogen. Releasing the egg causes you to start making progesterone, and the progesterone is the part that you had to get in the form of a shot with the medicated cycle, but in the natural cycle, we just supplement it with a little vaginal suppository. In a modified natural cycle, we will give folks some letrozole to get them to release to develop an egg and to release the egg. There are some people who feel like that the use of letrozole is very important because it makes the formation of your follicle and its growth predictable. In my opinion, if you make an egg on your own, if you release an egg on your own, if you ovulate, if you have regular periods, then the use of letrozole is not something that I personally would recommend. Dr. Kiltz, for instance, loves the use of letrozole and has there are a lot of folks, particularly depending on who your provider is or who the nurses are who are managing your cycle, may interpret orders as, well, of course it should have letrozole because that's what the way Dr. Kiltz likes to do it. There are others, differing opinions. I prefer not to use the letrozole in a natural cycle if you have normal periods, because you don't need it. You're going to build that follicle on your own. That egg is going to grow, and ultimately we can trigger it for release. The problem is, the reason why I say, why wouldn't we do it for everybody, is that, well, the way letrozole works is that it inhibits, it blocks the conversion of some hormones into estrogen. So it decreases your estrogen level. And that estrogen level you need for your endometrium, for the uterine lining. Now, Clomid, for instance, clomiphene citrate, after a single, usually by the time you're on a second cycle with Clomid for ovulation induction, Clomid will start to have a negative effect on the lining of the uterus. And so for that reason, we rarely use it here at CNY. Letrozole probably doesn't have the same measurable effect in most people, but it's certainly decreasing the estrogen, so it can have some effect. In my opinion, Delaney, if you ovulate on your own, I would not have ordered letrozole for your cycle there. Let's see what else we have here. We've got some questions over here on my Instagram side. Mike and Amanda from Houston. Hey, you'll be here this Friday, and we are looking forward to seeing you. What else have we here? Erica, thank you for your kind words. And what could be a reason for a high AMH but a low follicle count? I have an AMH of 7 at age 30, but only had 3 follicles at baseline, and I'm worrying. Well, so what you're really asking about there, Erica, is something that's called an antral follicle count, or an AFC. And typically, it's not something that we use all the time. In fact, at CNY, we rarely use it at all. It kind of gives a little bit of an overall gestalt that if you typically have less than 5 antral follicles, it may suggest that you're not going to do as well with your stimulation. So the first thing that would make me think about, Erica, is, have you been on some kind of suppression? So women who have been on birth control, for instance, and then stop, are often suppressed to the point where they don't have a lot of follicles. And I saw this in a friend of mine who came all the way out here to Colorado to do some egg banking. This is a friend of mine from Miami. And I always thought, was a very, very fertile person. She had been on birth control for a long time. She had a good AMH, but we kept her on the birth control until she was ready to start her cycle. And as a result, she ended up really with not very many eggs and not very many follicles, which was a surprise. But then, interestingly enough, she stayed off of the birth control. And a couple of months later, we had her go back and do a baseline, an antral follicle count. And she had gone from, having very few follicles to having 25, which is something more like what I would have expected. I want to send another special hello out to Devin. Thanks for being here, Devin. And let's see what else we have here. Got a bunch of questions in. I'm going to try to start giving them, getting to them all. Can we stop taking the HCG boosters before doing the beta HCG? So here's the story on HCG boosters. This is a very controversial topic, really, amongst kind of in social media, because what often happens is that you'll do a pregnancy test and your pregnancy test will be positive. And you say, oh my God, this is great. And then you repeat that pregnancy test 48 hours later and you come to find out, well, really what you were testing was the HCG booster. You were giving yourself HCG as a booster shot, the pregnancy hormone, and then you were testing that pregnancy hormone in the blood. So not surprising. In a natural cycle, in a natural frozen embryo transfer cycle, the HCG booster makes a big difference. It is metabolized in the body as progesterone, and progesterone is obviously very necessary for that lining of the uterus. And so we want it to do what it's got to do. We're going to boost that progesterone by giving ourselves the HCG booster. In a medicated cycle, the HCG booster really doesn't do a whole lot. In fact, the data shows us that, it makes you feel like you're doing something, but it's a rare instance that it's actually helpful, because in the medicated cycle, we are giving you so much progesterone anyway, that the little bit more you make from an HCG booster is not so critical. So if you are using your HCG booster in a medicated cycle, I would say, yes, you can really stop it at any point. If you're doing it in a natural cycle, I would strongly encourage you to continue it, with the understanding that your first test is going to give you a number that is going to require a second pregnancy test to resolve whether it's a real number or not. And that comes from Come Shop With Me. And I like that handle there. That's a good one. Here is Crystal. 10 years ago, I had my 5th C-section. My baby passed away at 1 year old, which was very painful. Oh my God, I can only imagine. My new partner and I would like to get pregnant, but I do have a tubal ligation. What are the challenges? Well, so Crystal, fortunately, with IVF, that's a common reason that folks will undergo IVF, that they've had their tubes tied, or maybe they've had an infection, or for some other reason have a blockage in the fallopian tubes. And so IVF is really a very straightforward process in that regard. Now, sometimes after 5 C-sections, it can leave some scar tissue inside the uterus. And so what I would recommend that you do before you think about putting an embryo back inside is that we simply evaluate the uterine cavity to make sure that there's no polyps or growths or bands of muscle or scar tissue or anything else that is going to prevent that beautiful, perfect little embryo that we are going to make from being able to implant in a beautiful, perfect location on the inside. Even if there's not scar tissue within the cavity of the uterus, sometimes, believe it or not, where the C-section incision is made, and not the one that goes on your abdomen, but rather the one that's on the muscle of the uterus itself, that's what's called on the lower uterine segment. The lower uterine segment, which is actually a portion of your cervix. So, if you've ever felt inside and felt your cervix, it has some length to it, and as we get more pregnant, that cervix begins to. It does actually. Well, here we go. It does three different things. The cervix starts to efface, which is to thin out, and it starts to dilate. So dilation as it opens up, effacement as it thins out. And then we also feel the third thing is where the baby's head is relative to some anatomic markers on the inside. But so sometimes after a bunch of C-sections, you can have some scarring in the cervix that can make us being able to access the uterine cavity more challenging. So that's kind of one of the potential challenges. But Crystal, to be honest, that's a very good reason to do IVF, and we can certainly overcome those challenges. Best of luck to you, my friend. So let's see here what else we've got over on the Facebook side. Actually, this goes back to the inositol question. Is it okay to take my inositol and metformin at the same time since I have PCOS? You're really taking extra of the same thing, but yes, you can take them together. The most common side effect that you will have resulting from that is bloating and gas and diarrhea and some stomach things, really until your body gets used to it. Do you know why that happens? It's because really the metformin or the inositol is driving sugar from your blood into your cells. And when that happens, it can damage some of those cells. Now, the cells, we turn over these cells, we grow new cells constantly, but those cells that line the intestine are very, very sensitive, and those are the first ones to often be affected. And as they start to slough off, that's what creates that GI kind of side effect. So one of the ways, or a couple of things that I do to try to get around the GI side effects, because again, most of the time people will get used to it. I like the extended release version of the metformin. I typically have people take it at night when you go to bed. And lastly, you start out with kind of one pill and increase to two after 7 to 10 days or so. And that gives your body a little chance to kind of get used to things there. Okay. This comes from Jen. It says, I'm doing my modified natural, but it tells me on my medication, and it says that I need to take letrozole 2 tablets once daily. So that's 5 milligrams of letrozole. And again, they have given you a modified natural cycle to make sure that you will produce an egg that will ovulate. So they've included ovulation induction with that protocol. 2.5 milligrams is the size of the letrozole tablet. Sometimes we use 5 milligrams, sometimes we use 7.5, and sometimes it even takes 10. So yeah, that's what that's all about there, Jen, and good luck. Tiffany's asking, what can I do to reduce inflammation in my uterus? So inflammation is the thing that, gosh, contributes to just about every disease process we know. Inflammation is what causes cancer. Inflammation is what certainly contributes to fertility problems. So Dr. Kiltz's answer to that would be dietary. And in fact, there are many people who would say diet has a great, tremendous contribution to inflammation in the body. Kilt says keto and carnivore, and that's one way to do it. The supplements, Tiffany, that we recommend either both for egg quality and for embryo transfer can decrease the inflammation that you have in your uterus and in your body. What supplements specifically decrease inflammation? Well, basically anything that's called an antioxidant. Antioxidants are designed to consume what are known as free radicals. What is a free radical? It sounds like some political thing, right? You've probably heard of free radicals, or maybe you remember it back from high school or some kind of thing like that, chemistry class. Free radicals. So when you metabolize something, let's say that you have a molecule of, I don't know, call it protein that you're going to break down. You break down your molecule of protein, it disappears in your body into its component parts, but there's often a little free-floating electron that just kind of hangs out, floats around. These are called free radicals. Depending on where you live, you may also know them as mosquitoes or gnats or no-see-ums. They're the no-see-ums of the body. That's what free radicals are. What do they do? Well, they don't bite you like a no-see-um or a mosquito does. Rather, they attach themselves to a cell membrane someplace. And when they do that, they damage that membrane and they create inflammation. So anything that's listed as an antioxidant is how you can decrease inflammation. And again, for that, Tiffany, I'm happy to send you the list of supplements. I can just send us a little message through Instagram, and happy to help there. This comes from Mariah. Hello, my friend. Do you recommend an ERA prior to the first transfer? I am 44 and I don't plan on any further retrievals. I have 4 tested embryos to work with. Well, so an ERA is an endometrial receptivity assay. And I want to be honest with you here, and sometimes just by my saying this, people are going to start asking to get ERAs, and I don't want you to do that. And here's why. So the ERA has really become very controversial now, and it's predicated on this idea that we as humans have a narrow window in which we can get pregnant, in which an embryo can implant. And if we're off timing there, then the embryo doesn't implant and we don't get pregnant. The ERA is predicated on this number of 120 hours of progesterone. So when you're doing a medicated cycle, it's 6.5 days of progesterone that you get before you get an embryo transfer, 120 hours plus or minus 3. And it was originally said that 75% of us fall into that window, which means that 25% of us are outside that window. And so maybe we need to test to see who is in the 25% and who is in the 75%. Well, so in general now, the belief is that's probably not the case, that we have a much wider implantation window than we ever really thought from before. So the ERA probably isn't so necessary. Now, it was explicitly studied in people who had never had a transfer to say, should we do this or not? Because there's a lot of clinics who perform, well, it's what I kind of like to call a wallet biopsy. It is a financial extraction technique because the test costs money. To perform the test costs money. And if your IVF clinic is saying, oh, you have to do this test, well, it's because they are able to charge you for it. The evidence on that, Mariah, was very, very clear that in people who had never had an unsuccessful embryo transfer, that doing an ERA was not helpful, did not benefit them at all in terms of improving the pregnancy rate. Now, I will tell you, we on the fertility side can all swear to having, any number of patients who had transfer after transfer after transfer were never successful. They finally did an ERA that showed that the timing was off. They were at 140 hours of progesterone instead of 120. And then we change it, and lo and behold, then they get pregnant. So I still feel like there may be a role for an ERA in some folks who have had repetitive failed transfers. But in your case, my friend, I would not recommend that you spend the money on an ERA before you've ever even done a transfer, because the evidence shows us it doesn't make a difference. All right, what else we got here? My friend Ruzik Blue from Las Vegas. If I'm suppressing with Orilissa, but got my period with regular 5-day bleed and regular cramps, does this mean I don't have endo and that the cramps are caused by another issue? No, it does not mean that. So what it means is just that the Orilissa, so Orilissa is a medication that we can use to medically both treat and suppress endometriosis. And in the case of the fertility world, when we find that you have endometriosis, the data shows us that if we suppress it for about 60 days, 2 months before doing your embryo transfer, we can significantly improve the odds of your transfer being successful. The old way to do that was with Lupron. Many of you have used in IVF have used Lupron as a trigger where you get kind of one shot. It may not really have much in the way of side effects when you use it that way, but Lupron in the treatment of endometriosis was there's a 1 month Lupron shot. You give it and it lasts for the entire month. There's another that's called Depo Lupron, which lasts for one shot lasts for 3 months. And what it does is that it shuts down the hormones entirely. And you can imagine that doesn't feel very good. Now, it may feel better than the pain that people were experiencing with their endometriosis, but going into temporary menopause to treat the endometriosis it's tough. It's tough. And so how do we treat that? Well, we would do something that's called some add back therapy. If we give you a little bit of oral progesterone back, it can actually, minimize some of those menopausal side effects that you have from the Lupron. Orilissa and Myfembry are now medications, oral medications that are available for the treatment of endometriosis. And what they do is that they turn the volume knob down on the endometriosis without shutting off the hormones entirely. So as a result, they are really better tolerated than the Lupron. If I were going to have to use it myself, 100%, I would rather use one of those oral pills than Lupron. So that's why we offer it to folks now. So that does not mean that you don't have endo. What it means is that you're just not completely suppressed from the Orilissa, but as long as you're taking it, my friend, it's doing its job. All right. How soon do I need to start taking vitamin E and L-arginine for an FET? Thank you for asking about L-arginine. I think I mentioned last week that is the one thing that is the supplement that most people forget in the list of supplements for embryo transfer, L-arginine. And when should you start taking it? Well, if you can take it even for the month before you do your transfer, I think you're getting some real benefits. So as far as using this handful of vitamins for egg quality, we know that 2 to 3 months seems to be the magic window, closer to 3 if you can get there. Sometimes you can't always get there, but for embryo transfer, using the supplements starts to have a pretty rapid effect on the endometrium. So start it in the month before. Let's see what else we have here. Gosh, it's about 10 minutes until the top of the hour. And you are on Fertility with Fink and Friends. I am Fink and you are friends, live from Colorado Springs. And we are so happy to have you here like we are every Tuesday at 4 o'clock Mountain Time. And so we'll be with you for about another 8 minutes or so. Let's see what else we can get here in terms of questions. Okay, I got some here. I know it. Lots of people joined here. Have you ever seen poor egg quality in patients at the age of 37, those who have had previous pregnancies? And the answer to that is yes. Yes, egg quality can affect us really at any time. And certainly as we mature, and that's the word that we choose to use, as we mature. Some would argue that I have never matured, but you know what? That's a conversation for another time. And let's not go there. Egg quality can change over time. It certainly changes as a result of aging. But sometimes we can just sort of be having a bad cycle for whatever reason, and the eggs that are sort of coming to the surface that we're able to retrieve just may not be great. So if someone has a retrieval, for instance, and they're not so successful with it, we like to look at a bunch of different features to see, well, gosh, what could we do to improve egg quality? And so the list of supplements is absolutely one of those things. A lot of times we'll look at omnitrope or human growth hormone, sometimes at low dose naltrexone for inflammation. And then you proceed and do another cycle and you have a completely different outcome, even if you used all the same medications. Now, usually we'll try to tinker with that as well, or some things about the timing of trigger and so forth. But yes, it's very common to have poor egg quality for whatever reason, that then the next cycle, we don't see it again. And that can happen at 37, that can happen at 27, So really anywhere along the line. Smoky Bear Bridges. I'm a CNY patient. I am not responding to stims. I'm on Follistim. So you are on our mini dose protocol, which is 10 milligrams of letrozole, 200 of Follistim, and 20 units of HCG. Only grew 4 follicles and only 2 got to 12 millimeters and stopped. I've been asked to stop stimming. Well, that is a frustrating thing to happen. There is no question. But so, Smoky Bear, if I were sitting looking at your protocol, I would say first thing I'd want to look at, I'd say, I wonder, how old are you? Because we're using a mini dose here, and there are many who subscribe to the theory of mini dose. And sometimes we'll say, well, gosh, that's still a little lower than what I would expect, your age-related dose or your expected dose for age. And when we change to that, we might get a very different kind of outcome. So that would be kind of the first thing I would look at. And I think that is worthy of a consultation. But, what I will tell you is that to have to stop stimming or to cancel a cycle is a hard decision to make. It's one that we don't like to make because you've invested a lot, not only financially, but gosh, emotionally. The emotional capital that you spend on that is significant. So to have to cancel a cycle is not something that we take lightly. But when we do make that recommendation, it's because we feel like you've spent enough money on your medications. And if it doesn't look like things are working, it means we should really start from ground zero. Let's go back to the drawing board, figure out what didn't work right here and what, if anything, we can do to make things better next time. So I will certainly wish you all the best with that. Okay, does genetics matter when it comes to using sperm donor? Please touch on genetics. So it does, because many of the sperm banks, if you're using an anonymous donor from a sperm bank, the sperm banks will now test all of these embryos will test all of their donors to see if they are carriers of any of these genetic diseases. Because if you're a carrier of a genetic disease, you don't want to pick a donor that is a carrier of the same genetic disease. Why not? Because then you have a 1 in 4 chance of having an affected pregnancy. So you can definitely, so they will test those donors, and strongly recommend that you pay attention to those genetic things, because they do make a difference. Let's see here. How much fish oil should I be taking? Oh, that's a good one. Fish oil. So first of all, I think I said this last week. If you're taking fish oil, make sure that you take the one that says odorless or burpless, because most of these things come from sardines. And the first time that you burp that up will be the last time that you ever want to take your fish oil again. There's no specific recommendation on fish oil. So it just depends. There's one that I recommend that's called oh gosh, I'm blanking on the name of it, but it's 850 milligrams of EPA and DHA, made by Orthomolecular. And with that, you just have to take one of them. Most of the fish oil supplements that you'll see, you take 2, just because the concentration is a little bit lower. But honestly, because there's no recommended daily allowance of omega-3 or of fish oil, it is something that anything you get, it's better than nothing, as long as you don't burp it up. And if you do, please turn your head the other direction. Oh my God. All right. I think we have time for maybe one more question here. Let's see. Is it okay to take Ovamax? I am now in my monitoring phase and getting ready for a natural modified transfer. Ovamax, I presume, is a supplement. I have heard the name of it. I don't know exactly what's in it. I would simply look at what's on the label. You can compare it to what's in the list that comes from the book. It starts with the egg, and that will give you some guidance there. Yep, this comes from AZ Signatures, and it touches on a couple of things that we mentioned before. And that is my embryos are graded high quality, but after PGT testing shows that they are mosaics. Can I still transfer a mosaic embryo? Please watch this back from before because we talked at length about mosaics a little bit ago, and the answer is absolutely yes, my friend. Well, it looks like we are going to be out of time for this Tuesday afternoon. I hope I was able to get to your question. And if I didn't, please join me next week. Join Dr. Kiltz. He's around. Gosh, he may be on almost every day, but we got lots of opportunities for questions and answers. It is my privilege to be here with you every Tuesday afternoon for Fertility with Fink and Friends. Remember, your fertility journey is just a journey. It is not the destination. Fertility and its problems are not your book. It is only a chapter. And what we're doing is to help you rewrite that chapter. God bless all of you. Thanks so much for being here with me today. And I'll look forward to seeing you next week. Good night.